So I'll have you give me like a fake scenario though with it so they can see like what the verbiage will be. Like we said for the respirations, if they're shallow and slow or shallow and fast, it's inadequate, or you say shallow and maybe elevated but adequate, or shallow and slow but adequate. That's a lot of the verbiage we're giving.
Okay.
So the only thing we're gonna have is a blanket down here, we're not
Yeah,
gonna
we
put
just have-
BDM or anything, we'll just
No,
say
nothing else.
wood.
I pretend this is my blanket.
That's
so I
our
don't forget
blanket.
it. This is my
I like it.
blanket. Okay, so.
We're gonna wear,
See if I can just find one
I'll show
online.
you one.
Okay, yeah,
That's
give me
some
something. Cause you need to give me my dispatch, and then I'd like ask her for my general impression, she's gonna feed it. I
Okay.
get my vitals, she feed them. Okay,
Okay, ready?
yep, what's my dispatch?
You're dispatched to an accident scene involving a middle-aged man who has fallen from scaffolding. His coworkers report he fell from approximately 30 feet up, landing in the dirt below. Upon arrival, you find him lying on his back with clear deformities in his left arm and blood on his pants around his left femur. He's unresponsive, although he appears to be breathing.
Okay, when I ask my general impression again, I'll probably have you give that again.
Okay.
So I got my dispatch, whatever else that included my general impression. BSI is my scene safe. My scene will be safe. I'll come up. I'm gonna do my snack, so scene safety, nature of illness, it's a fall from probably about 30 feet. My second in is number of patients. I just have one patient.
Yes.
Okay. I'm gonna put ALS on standby, given the nature of this. And given the fact that it was a fall, not only am I considering C-spine, I'm gonna say ghost medic. Go ahead and hold C-spine, make sure that it's in that midline stable position, okay? So that's snack. I'm gonna come over, go into GLC. So you gave me my general impression already. This one would be a little different because he does have bleeding, so I'd wanna make sure I'm assessing that. But I asked her general impression, she said unconscious. And I'm gonna try to check to make sure he's awake, even over level of consciousness. Hey, can you hear me? Can you hear me?
No
All right.
response.
Making sure he has a pulse. Pulse should be present. At this point too, because she didn't mention there was bleeding, I would ask, is it a massive hemorrhage, right? In our scenarios, they're not generally going to be, okay? So level of consciousness, GLC, and then, what am I forgetting?
Level of consciousness.
Oh, chief complaint, he's unconscious. And then I would go into my A, B, C, D. So I'm gonna go ahead, because of the fall, I would do not a head tilt chin lift, but the jaw thrust. And I would look for his airway. Is his airway patent?
Patient is snoring and gurgling with red tinged sputum.
Okay, so if there was anything in his mouth though, there's nothing there, like the sputum's just around? It's not interrupting his airway?
No.
Okay, so I would go ahead, because he's unconscious, I would do an OPA, insert my adjunct. I'm gonna go ahead and assess for breathing, look, listen, feel. What do I see?
His breathing is slow,
Okay, is it shallow, fast?
shallow, and adequate to support life.
Okay, if it's adequate to support life, I'm gonna go ahead and I'm gonna have my ghost medic get my non-rebreather set up at 15 liters per minute. Does my patient tolerate?
He tolerates.
Okay, I'm gonna throw a pulse ox on him just because I want to at this point. So that's my A, B, did my breathing. C is circulation, so there's a couple things we're checking. I'm gonna check my bilateral radial pulses. How do they feel?
They're rapid and weak.
Okay, noted. I'm gonna go ahead and check my cap refill on those. Cap refill's present?
Present.
Okay. I'm also gonna look at his skin. What does it look like, feel like?
It's cool, clammy, and pale.
Okay, cool, clammy, and pale. At this point, I'm gonna take my little blanket. I'm gonna treat for shock as well. From there, I did my ABC. Given this, I'm gonna decide we need to get him and go, okay? So decision transport, we're rocking and rolling. We'll get him ready for transport, get out of here. So I'm gonna move into vital taking, which for your skill sheet, that's just how it goes. Take my blood pressure. I'll take my pulse for at least 30 seconds. I'll count my respirations for at least 30 seconds. I'll see how my pulse ox is reading. If they had 100, I'm gonna knock down my non-rebreather a little bit. If it was like 93, I'm gonna keep him on my non-rebreather. I put him on 15, so I'm already up there. So that was that portion. I could ask if anybody was around. We know that he fell at least 30 feet. That's something I'm concerned about, obviously. But other than that, you're probably not gonna get a sample history for our scenarios. So I move into my rapid trauma assessment because I got vitals. I attempted to take an ample history. And I do head to toe. So they're still holding C-spine. I'm gonna feel around the skull. I'm looking for DCAP, BTLS, anything like that. I'm gonna look in his ears. I'm looking for cerebral spinal fluid, CSF, or blood. Gonna check the nose, make sure nothing's there. Gonna look in the mouth, make sure that my adjunct is still in place. Obviously, as I'm not a breather on, so just kind of taking that as it is. I like to go ahead, I'll palpate the cervical spine. Do I note any step off, tick, anything like that? Any deformities?
No deformities on the back.
Okay, perfect. I'm also gonna look at his neck itself. I'm looking for JVD, so jugular vein distension, and then that trachea deviation, so is my trachea still flat and midline? If everything looks good, at this point I'm gonna go ahead, I'm gonna grab my seat collar, and I'm gonna work with my Ghost Medic. We're gonna put this on, I'll measure it, secure it. Life is great. I'm gonna work my way down, keeping it covered. I'm gonna palpate the clavicle, feeling to make sure everything's stable, any crepitus. I'd also be exposing, do I see anything? Okay, I'm gonna check the crepitus here. I'm also gonna reassess my breathing, get an idea how that's feeling, although I already did my respirations. This is just making sure he's holding okay. I'm gonna keep moving down. I'm gonna go to his abdomen. I'm not gonna suffocate him in a bag. I'm palpating for turd P, seeing if there's any tenderness, rigidity, any swelling, discoloration, anything like that.
Nothing noted.
He doesn't have any type of pain response anywhere thus far. I'm gonna go ahead and check the pelvis, so I'm gonna close the book. Is it stable? Do I feel anything?
Pelvis is stable.
Lovely. Since it's a male, I'm checking for priapism. Negative or?
Negative for privacy.
Okay. I'm gonna go down my legs. Like I said, I like to get here just because I'm still kind of checking for bleeding. I remember you mentioned there was bleeding here, but it wasn't life
Bleeding
threatening.
around the left femur.
Okay, I'm on the right side. So I'm gonna palpate really gently here with the bleeding. How bad is it?
It's not.
It's just like an abrasion?
Just, yeah. Just,
Okay, I'm gonna note that there's an abrasion. When I do my secondary assessment, I'm gonna treat at this point. So I'm gonna palpate really gently around here, make sure that bleeding isn't anything major. Do I feel any crepitus? Do I see anything else?
You do feel slight crepitus around that femur.
On the left femur only
Yes.
though. I'm gonna very gently make sure my joint's good. Everything's good there. Everything's good here. I'm gonna Babinski. I'm checking to see if he has a sensory response. Does he respond?
Yes.
Oh, good. So he's at least a little reactive to pain. I'm gonna keep that in mind for my Glasgow-Coma scale as well. Okay, I'm gonna check my cap refill. Hey sir, can you feel this? Can you wiggle? Oh, he groans when I touch him? Great. I'm also gonna go ahead and check for a pulse. Is pulse present? Okay, same thing on the other leg. Any crepitus on this side, any bleeding?
No crepitus, no bleeding.
Okay. Does he respond to that?
Yes.
Can you wiggle, can you feel? Does he wiggle or anything?
Kind of moaning.
Do I have a pulse?
You do have a pulse.
Okay, this is good too. So that was my CMS on the legs. I'm gonna work my way back up. I'm gonna check his arms. Same deal as the legs. And you had mentioned there was something over here, but it wasn't massive again.
Yes. Just like some venous bleeding. Just a little bit.
Okay, just some abrasions again.
Mhm.
No crepitus notice or anything like that?
No
swelling?
crepitus.
Okay, I'm gonna make sure his joints move okay. Check a cap refill. Is my pulse still present?
The pulse is present.
Is it improved at all?
About the same.
Okay, hey sir, can you feel this? Scratch him, same
Yeah.
response. Great, same thing on this arm. And this arm's fine, I don't see any scratches, no crepitus, nothing like that.
No.
Pulse is still present, they're equal feeling. Can you feel that? Cap refill, looks good. So that was my rapid trauma for the most part. Then I would wanna get him, before I put him on the spine board, for me personally, if this is a slight fracture, a suspected fracture, I'm gonna go ahead and splint that at this point. I can try to dress him a little bit more when he's on the board, but not secured, real life, okay? And then I would get on the patient's uninjured side, for in real world. But for this scenario, you're gonna roll him, you're gonna check his back. 1, 2, 3. It's on the headman's count because he's still holding C-spine, he has that collar on. I'm gonna get it up, I'm gonna walk my hands down his spine. Do I feel anything? Do I see anything?
Nothing noted.
Nothing noted. Okay, how about here? How's negative for buds?
Negative for buds.
What is that? Blood, urine, defecation, sphincter tone. I'd have somebody grab my spine board. We're gonna put it underneath him on the headman's count really gently. 1, 2, 3. He goes on the spine board. Like I said, I'm part of my secondary right now. I could potentially treat a lot of this, but given the nature, I'll treat it while I'm in the ambulance. So I'd put him on the spine board. I'd go ahead and I would start securing him. So if I see any type of gaps or whatever, I take Curlex, probably under the waist, maybe on the legs or between them, especially with that splint there. Then I would go chest, waist, legs, head. And now we're able to go ready and we're gonna load up. He still has his blanket on him, obviously, because we're so concerned about it. While I'm in the back of the ambulance, I would clean up those wounds, any abrasions that I could, wrap them if need be. I'm gonna reassess my patient every 5 minutes, which is retaking vitals, making sure that my interventions are still working, my adjunct's still in place. Anytime you move a patient, you're also reassessing that, just for safekeeping. So if you get a second set of vitals, she'd give that to me, and then I'd do a handoff. Essentially, I'd say, hey, this is medic 1, I have 1 male patient, fell roughly 30 feet, patient is unconscious, crepitus noted in left femur, abrasions to left arm, treated with a splint, is currently on a non-rebreather at 15 liters per minute. His vitals are 1, 2, 3, trending positive or maintaining. Do you have any questions for me?